Good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19, infection control, and other nursing home related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist at Quality Insights. Today's webinar is end-of-life care, palliative care, and more. Everyone has entered the meeting on mute, but we will have a Q&A following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. We invite you to join us every Wednesday for more of our weekly webinars. Next week's topic is education for nursing homes on sepsis prevention and enhanced barrier precautions. If you are interested in joining, that will be the same time and place next Wednesday at 2 p.m. And now I'd like to introduce our guest today, Shelly Zito. Shelly is a community liaison at Connections Life Care Hospice in Mount Carmel, Pennsylvania. She has 33 years of nursing experience, as well as 15 years of experience with care coordination, marketing, and care in the hospice field. Shelly, thank you for joining us today.
Thank you so much, Kathy. I really appreciate it. Thank you, everyone, for having me. I had recently met Deborah Wright at another meeting that we were at, and she had mentioned that you guys might be looking for some information on palliative care, hospice care. So I've been working in the hospice arena for quite some time. And the first thing I wanted to do was to give you my objectives. The objectives today, we're going to talk a little bit about palliative care versus hospice care. We'll talk about the hospice team and some additional services that we offer. We'll talk a little bit about the hospice program goals, a brief insurance overview, different diagnoses that we take on hospice care, and different levels of care and where our services actually occur. So a little bit about palliative care versus hospice care. A lot of people get confused and they don't understand what the difference might be between the two of them. And it always seems like people readily want to be on palliative care and do not want to be on hospice care. So the information on that is palliative care is care that is given for a serious illness. It's to alleviate stress and symptoms of a serious chronic illness and relieve some of the stress that is brought on by for the caregivers that's brought on by all of this. And it's alongside of curative care. So when you're on palliative care, you will be able to still continue with your curative care. If you have, God forbid, a cancer diagnosis and you're still receiving treatment, you can receive palliative care in your home or wherever it is that you call home, while you're still receiving that curative care. Palliative care, I like to think of it as home care. It still falls under the category of home care, and it's still paid for through insurances, as if a home care service, somebody coming into your house for PT, OT, or skilled nursing would come in and bill for their services. Hospice care, which I'm going to talk a bit more about today in detail, is comfort care. So there's no curative care that is involved. And the goal of hospice care is care of a patient who is given a diagnosis of 6 months or less, wherever they might call home, which would be a skilled nursing facility, an assisted living, in their own home. And I'm going to talk about that a little bit later on in some of my slides. The goal for both of these types of care, hospice and palliative care, is symptom relief, and both of them are compassionate care. Both of them center around helping the caregivers and helping the patients through a stressful time, which may warrant different outcomes. Palliative care, it might actually warrant, somebody going into remission. Whereas hospice care, you're generally giving a diagnosis of 6 months or less. What I will tell you about hospice care is that what we generally say sometimes is we might get a call for a hospice referral, and we'll have people that will say to us, I don't even know if the patient's going to make it out of the hospital. That's how ill they are. And we will let you know. And then all of a sudden, the patient does make it home. Our hospice services go in, and because of the extra added attention they're receiving from our hospice team, they're actually getting more time to spend with their loved ones. And we've got some people who have benefited so much from that, where we went from, we don't know if you're going to make it home, to now this person is, going to the bathroom. They still have a terminal diagnosis, but they're able to get up and live their lives a little bit longer with their loved ones. They are able to care for themselves, go to the bathroom, shower, and do that type of stuff. So hospice care is not always doom and gloom. Whenever I mention hospice care to anybody, I always get that sentiment, like that must really mean I'm going to die. Not necessarily. And we don't go in with the intention of, we go in with the intention of helping you and helping your loved ones cope with what's going on, and develop a care plan so that we can take care of you and hopefully give you some more time to do the things that you want to do, and to be with your family. A quick philosophy for hospice care is a philosophy of care to assist those who are at the end stage of their life. It originated in England, hospice care. If you've ever watched Call the Midwife, there is an episode that there's actually a couple of episodes that kind of lead you to believe that that's where hospice care originated from. The first hospice in the United States was in Connecticut, and it's fast growing. There are currently over 3,500 hospice programs in the United States. Some of the hospice team that are involved when you call for hospice care and you put a referral in, our referrals come from all over. Our referrals are, sometimes they're self-referrals, sometimes they're family referrals. Sometimes we get a referral from the community. I do a lot of talks with the community centers and some of the groups in the community for aging, and we get some referrals out of there. A lot of times our referrals are coming out of skilled nursing facilities or assisted livings. So that referral comes in, it comes in through a fax. What we do as a team is look at it, determine when we could handle the admission, find out what the family or the patient or the caregiver, find out what's convenient for them, and then we schedule the admission. Some of the folks on the hospice team is physician directed. We have a medical director that we do IDT meetings every Friday, and we review over all of our cases and take care of any paperwork that might be necessary in conjunction with these cases. And our medical director is generally available for any orders we might need to have signed, or any questions that we might have, or questions or comments, or any insight into our plan of care. A next big part of the team is our nurses and our nurses aides. Generally, with our hospice care, we see nurses go out 2 to 3 times a week, and we see an aide go out anywhere from 1 to 5 times a week. It depends on what stage the patient is at, how critical they might be. Somebody who is actively dying, of course, we're going to get in there and we're going to have somebody in there daily and provide a daily nursing visit, so we can, be with the family and, be with the patient while that's occurring. Somebody who's up and active, although they might have that terminal diagnoses, they might be able to take care of themselves. So we kind of keep a cautious eye on them. We come in as per the family or as per the staff of the facility. What we do is we work with them and we say, how's Mr. So-and-so doing? Doing good today. We can keep it at one nursing visit and maybe two aid visits. We kind of, look at it on a day-to-day basis, on a weekly basis to see what care the patient might need. We have a social worker on our team that's very, very instrumental in working with us. And our social worker at the agency I currently work at is a godsend. She knows everything from billing questions to community programs to waiver programs to any sort of question the family or the patient might have. We institute our social worker, we call her up if I'm at a luncheon program, or if I need her help with a question, she's readily available. I can call her on the phone and she'll give us instant answers. So social worker is prime caretaker in this whole team. Basically what she does is she does weekly hospice visits. And as soon as a patient is admitted, she goes out right after that patient is admitted and meets with the patient, meets with the family, and gathers all that information. Physical, occupational, and speech therapy could be provided if it is based on, a lot of people say, well, it's hospice services, everything stops, when a hospice service starts, there's no active treatment. It's not necessarily always like that, because if the patient is in need of some sort of service to help them with pain control or something that is related back to the terminal diagnoses, we can definitely get an order for a physical, occupational, or a speech therapist to come in. We currently at our agency don't have a dietitian, but we do have access to a dietitian, as do most agencies. My company happens to belong to a larger company, and we do have dietitians on staff if we have anything with regards to the diet of the patient. What we do is we get in touch with that dietitian and try to set up a consult. Chaplain bereavement services. We have these folks on board. They're really great to have because not only are they a care and a comfort to the patients and the patient's families, while the patient might be dying or in the process of actively dying, we also run a bereavement group. So a lot of these folks are in charge of bereavement groups for the communities. So even after the loved one might have passed away, you might see some of these folks show up at our office for some of these bereavement groups. And we take everybody. I get a lot of questions every day. Well, we didn't have anybody on your hospice service, but we know somebody who's in need of these bereavement services. Her husband just died. Can she come to your group? Of course. We open that group up to the community. Another thing we have is volunteers. A lot of the volunteers we have come out of some of the meetings I have with some of the senior groups in the community. Like right in Mount Carmel, we have a senior center that I go and we participate in some of their programs. We provide services for them, any type of continuing education. And in turn, a lot of them like to volunteer and come over and put an hour or so in whenever they can, right in the hospice office. And they do mailings for us, and they'll make phone calls and do whatever is necessary. Next slide. So our hospice program goals, the main goal that I talked about a little bit earlier was an emphasize on living. So we don't come in doom and gloom. That's not our motto, especially at where I'm working right now. That is not our motto. Our motto is come in, take care of the patient, make sure they have a good quality of life, make sure they're living the life that they want to live. They're getting everything they need, all the services that they need. Their pain is under control, and they have that time to spend with their family, their loved one, or caregivers. Some of these folks who take care of them in the assisted livings and the skilled nursing facilities become very close with some of these patients. So us as a hospice agency, we always have to go in and we always have to make sure that we're taking care of those folks too. We promote a quality of life. So if we, a lot of people say, oh, you just go in and you drug people. Hospice is as far away from that as possible. The medication portion of it, we start managing medications from the minute that we bring the patient on board and we develop a care plan. But we generally include, I shouldn't say generally, we include the hospice patient, we include physicians, we include other caregivers, we include everybody who needs to be in on the care for that patient. We include them on the medication management, and we tailor the medication to the needs of the patient. If a patient is doing well, and they can get up and they can go to the community room and they can enjoy some activities with their fellow residents in an assisted living or a nursing home, by all means, what we're going to do is, take cues from them, and we're going to let them enjoy, whatever they feel confident and whatever they need to do in a day. We're going to let them do it. We encourage honesty and hope. So we never go in and tell anybody that, oh yeah, it's bad. It's really bad. You have a terminal diagnosis, and we expect, this is it. We're honest. We talk about what the doctor said if the patient wants to talk about that. We talk about anything actually the patient wants to say, and we encourage hope. I mean, we encourage that if you want to live your life to the fullest and keep doing, what you want to do, and up until the very end, we're there to support that. We will do what we can possibly do to take care of you, keep you out of pain, and encourage you to participate in what you want to participate in. We have a rapid resolution of symptoms. So that means once symptoms start, sometimes patients can take a turn pretty quickly. Sometimes you can see them, you know, uh, their strength and their energy and everything diminishing on a day-by-day basis. Sometimes it's over a period of time, but whatever the case may be, we have a rapid resolution of symptoms. And that even goes for, I had a gentleman that we have on hospice care, and I got called in one night and I was told, oh, he must be dying. The gentleman needed a tuck for a hemorrhoid, was what the problem was. So no need for morphine, no need for any of the strong drugs that come in the hospice comfort care pack that is kept on site. No need for any of that. The gentleman wanted a tux for a hemorrhoid that he was experiencing difficulty with. So we have to definitely go in and we have to kind of talk to the patient, talk to the caregivers, and kind of get to the root of what's going on in the moment. We do prepare the family and the caregivers and also the caretakers for death. So we like to try to call team meetings. We like to keep everybody posted and upfront. If we see a turn for the worse, like I said, we're honest with everybody and we will tell everybody right up front. We see a turn for the worse, we think this is what's going on. And we might see, the symptoms increase as we're going on now, from going this way forward. And we try to prepare everybody for what happens. We encourage questions. We talk to everybody, with regards to the dying process. And I will also sit with staff, and I have sat with staff at a number of skilled nursing facilities and assisted living, and just answered questions. Well, what does it mean if they feel cold? And will we hear that breathing at the end? And will their ears get pointy? I get all of those questions, and I will sit and answer all of those questions on a case by case basis and try to make everybody feel as comfortable as possible as to what's going on. And we always like to say in hospice, we're with you. Like, we're not going to sign your patient up for hospice and disappear. We always like to say, I have a family that calls me on a daily basis And it's, she called me yesterday and she said to me, "What does CNA mean?" And I'm like, "Well, that's certified nursing assistant. And here's her job responsibilities. And here's what she's going to do. And here's what she should be doing in the house." So no question is a dumb question. And I encourage the questions, and I encourage, even about death, I encourage the questions, and I'd like to get everything out up front. Continued support after the family is, after the death. That's one of our big goals. Like I said, we do have a bereavement group, and we do like to utilize that bereavement group for anybody in the community, anybody from any of the assisted livings, nursing homes, from their home, anybody that needs to come to that group and to come and stay for as long as they need. The next slide. Different insurances that we take. We take Medicare, we take Medicaid, and we take private insurance, and we do take VA insurance. Hospice will take VA insurance. The big deal with hospice is there is a Medicaid hospice benefit for patients who are 65 years or older and who are eligible for that hospice Medicare benefit. And once you turn 65, everybody is eligible for that. And Medicare takes over the cost of paying for everything. So we work in conjunction with Medicare. We will work in conjunction also with Medicaid and a private insurance, and working with the cost of anything that is related to the diagnosis, to the terminal diagnosis. So if your patient needs pull-ups or a pad that goes underneath them when they're sitting, or if they need a bed, if they need a bedside table, if they need the mouth swabs for their mouth, their medications, anything that is related to their terminal diagnosis, we pick up the cost. And we do work with Medicare, Medicaid, and any private insurances, and also the VA insurance. The next slide. Hospice criteria. We do use criteria to evaluate patients, and we just don't take patients that say, they call us up and say, "We want, our mom on hospice. Can you come put her on hospice?" There's criteria that has to be met, and there is a discussion that has to take place between our director of clinical services. She's like the RN that runs all of the RN and the aides, everything that goes on clinically in our office. Sometimes there's a discussion with our medical director, and a lot of times all of these discussions that take place beforehand will be in conjunction with the provider. So, it'll come from the physician's office. I get involved in a lot of this hospice criteria and putting forth the phone calls. We like to do same-day admissions. And I get involved in a lot of this, and different criteria we look at is the diagnoses, the determination of a terminal diagnosis. A lot of people just say, "Oh, my mom," it's like failure to thrive. My mom's not eating, she's losing weight, she just doesn't feel like living anymore, she's not going on. We can't just slap her on hospice because she's tired and her body seems tired. We need a diagnosis, and it's got to be something like a cancer diagnosis. It's got to be end-stage liver disease, end-stage congestive heart failure, any of the end stages, or it's got to be a diagnosis of dementia related to Alzheimer's or related to Parkinson's. And it's got to be either more of the end stage. If somebody gets on Alzheimer's or gets an Alzheimer's diagnosis, they're in the early stages, and they're still taking medications for Alzheimer's, and they're trying to lessen the symptoms of Alzheimer's. We cannot put that patient on hospice. We would not be able to take that diagnosis. But if this person has had, Alzheimer's for a good number of years, and they're starting to fail, and they're starting to exhibit symptoms of dementia, we by all means could get them on our service, and we can start taking care of them, start managing their medications, and helping the family or the caregivers determine what this patient needs, for the last part of their life. We need a primary caregiver available. It's very hard if there's a homeless person on the street, if somebody decides they need, somebody can't just say, hey, this guy needs to be put on hospice. We need a primary caregiver. So that homeless person needs to be seen by a physician. Something needs to be diagnosed by that physician, and they need to be living in a shelter. We need to have a place that we can go and actually provide them treatment or therapy. In the home, it needs to be, a spouse, or it needs to be a child, or not a young child, but adult children. A lot of times take care of their loved ones. In a skilled facility, of course, we have the care providers in a skilled facility. Same thing with an assisted living facility, and we always have that primary caregiver on board. A patient or a family needs to choose the hospice philosophy. So it's not like we could say, or a child, an adult child can say, put my mother on hospice. If that patient, who you want to put on hospice is still capable of making their own decisions, they need to be involved in the communication and in the conversation as to if they want to be on hospice or not. They need to understand what hospice is all about, and they also need to understand what it means. If you have a 58-year-old patient who's got a terminal lung cancer diagnosis and nothing is working, but that patient wants to, continue to seek treatment, continue to seek therapy, calls you up and signs them up for hospice, but then keeps refusing the hospice nurse. They have not got a grip, or got themselves around that hospice diagnoses. They have not, they don't feel comfortable, and we would never admit somebody, and nobody should ever admit somebody to a hospice that does not feel comfortable. The family needs to feel comfortable with it. If you're coming into the home, the family's got to understand what's gonna take place, and that yeah, we're not going to go for physical therapy every day unless they would need it for their diagnoses. We're not going to continue with the chemo medications. This is the care that we provide. We provide comfort care. They have to understand the difference between what the hospice philosophy is, and actually continuing with or seeking out care. Now there are some instances where, if somebody needs a pleural, like for pleural effusion, or needs a catheter, some of that stuff can continue. So it's got to be a definite conversation between, here is exactly what we can and we can't do, and you have to have agreement. I know myself, never feel comfortable with a family. I will continue to answer questions until they feel comfortable with a hospice diagnosis and a hospice agency coming into their home. A physician has to certify the terminal diagnosis. So we need their primary care person or their specialist or whoever they're dealing with. We need them to call up and say, please provide hospice. It's a referral for hospice care. And please refer to hospice. It's a hospice diagnosis. Once the hospice is in there, we're responsible for the coordinating all of that care. So that doesn't mean we come in, we take everything over, and that's it. Nobody has a say. What that means is we come in and we coordinate all of that care. So if the patient needs durable medical equipment, one of the first things we do is I'll call up the home. I'll call up whoever the caregiver is in the home, and what I'll do is I'll say, what do you have there? Do you want a hospital bed? I always try to make them feel as include it as I possibly can. That is what our goal is. We are trying to give the family, more control over this. We're trying to make the family feel comfortable with what's going on. You don't want to take all that decision making away from them. And it usually works really well. I'll get the phone call. Sorry, we were supposed to have a potty seat in the house, a commode, and it didn't come. Or can you help me do this? Or mom's legs look really swollen today and it's not normal. It's not normal. Can we talk about this? We always get everybody involved that we could possibly get involved, and that we could examine what the issue is and take care of it immediately. Hospice is responsible for okay, so I said that, and hospice bears all the financial responsibility. So, a lot of people will say to me, how much does hospice cost? Well, hospice shouldn't cost you anything. If it's related to your terminal diagnosis, it either goes through your hospice Medicare benefit or it goes through whatever insurance you have. I recently had a gentleman who had he did not have the hospice Medicare. He wasn't old enough for the benefit. So what he had was VA and what he had was Medicaid. So we take care of both of those. We take both of those at our office. And I said, whoever you want us to put it through, if you want me to get it through the Medicaid, we will, put it through and we will authorize it. And whoever we can get the authorization back first. And a lot of times it's not the VA. A lot of times it is Medicare that will come back and say, yes, we authorize this. So some of the benefits, next slide, some of the benefits of hospice, Medicare hospice. It's a team approach. So like I said, we don't sign you up and leave you, and you'll always be talking to somebody, whether it is our bereavement coordinator that called you, whether it's our social worker that reaches out, whether it's myself, our director of clinical nursing services, and it's all coordinated. So we try not to make it seem like we're overwhelming. If the coordinator, the bereavement coordinator calls, the social worker calls, the aide was in there, like all that occurs in one day, I am not going to call and say, hey, I'm going to let that for another day. I'm going to make sure they know that there's somebody reaching out for them on a daily basis. Or we're going to ask, are you overwhelmed? Do you want to, let you be for an hour, let you be for a day? And, we could start some of this stuff back up again. So we try to do what's right for the family. Like I said, all the medication, supplies, and equipment related to the terminal disease are covered 100%. Acute care, we have different settings. There can be acute care in the facility setting for uncontrolled symptoms, or if there's a collapse in the support system or imminent death. So if we've got a patient in a home, or we've got a patient in an assisted living facility, and the symptoms are getting very acute and they cannot be controlled by the hospice nurse, what we will do is we will find a place that we can potentially put the patient in an acute care setting, whether it be like a hospice house, or, excuse me, whether it be like a hospice house or the hospital, to take care of these acute symptoms. And as soon as the symptoms are under control, they can come back home. The cost is covered by Medicare 100% with that Medicare benefit. There is a respite benefit. So if you have caregivers who are just exhausted, I have a family right now that has a mom and a dad who are on hospice, and we're taking care of them in their home, and there's 3 children. So it was explained to them that there's a respite benefit for both of these people. What that means is we have contracts with different places, including nursing homes, skilled nursing facilities, that we can actually, call up the skilled nursing facility and say, hey, they're going on vacation for a week. They need a break. Caregivers just need a break for a couple of days. do you have a spot to put these folks? Can we put these folks in there, for a couple of days according to our contract? And that's what we do. And sometimes everybody most of the time refuses that in the beginning, but I'll tell you what, sometimes it's very difficult caring for a hospice patient, let alone two hospice patients. And they need a break. They will definitely say, this is getting to be too much. I'm too in it. I'm too present every day. I need a break. I need to breathe. So that's what we do. We start looking around for some place that, we have a contract with, or some place that can actually take these folks and keep an eye on them for us for a couple of days. And we give the caregivers a break. And we also have another benefit of Medicare Hospice is ongoing support for the bereaved family. Next slide. So our levels of care are routine home care. So routine home care is we visit you wherever you're calling home. So if you're in a personal care home, if you're in assisted living, if you're in a skilled nursing facility, if you're in your own home, if you live in your daughter's home, if you are incarcerated in a prison, and they need a hospice team to come in, wherever you call home, we will come in, and we can do routine hospice care. We do general inpatient care. So that is if we were just talking about if somebody needs acute care, if the symptoms are uncontrollable at home, and we need to call an ambulance and we need to get that person to the hospital, or however we need to get them there, we will get them there, and we will continue that care in the hospital until the symptoms are under control, and then bring them back home. Respite care, that we just talked about, respite care for the caregiver who's experiencing stress. And then there's continuous care. And continuous care, I was really surprised because I've been visiting some of my personal care homes and assisted living facilities, and our agency offers continuous care for when a patient is dying. So what that means is there'll be an RN that comes in every day. There'll be an aide that comes in every day. And I'm not sure if a lot of agencies don't do that, but we do offer continuous care, and it's just a nice benefit to have that hospice person there, through the different stages of somebody who might be actively dying, because they can calm the nerves of the family, they can calm the nerves of the staff, they could answer questions, and they can be there, for the different stages of, death and dying, and how to walk everybody through it. The next slide, where our services can occur, we just went over some of this. It could be in home of a relative, it could be a skilled nursing, assisted living, hospice home, shelter for the homeless. We will go into a shelter for the homeless. A lot of times, some of these folks go in through an ER, they get a primary care, and they get sent to a homeless shelter because they are actually have nowhere to be discharged. And then we get called in, and we will go into a homeless shelter for hospice care. Common diagnoses, next slide, for hospice. Some of our common diagnoses that we treat and we see are cancer. That's a big one. End-stage heart, lung, renal, or liver disease. I would have to say that lung disease, heart disease, and liver disease, actually even renal disease, we are seeing a lot of it. I don't know if that is because of the area that we live in, and some of these older folks, the jobs that they had, in the mines and stuff when they were younger, but we're seeing a ton of that in this area. Somebody has a stroke or a coma, or is in a coma, wherever they're at, we will come in and we will provide hospice care for that person. Somebody who might be experiencing the latter stages of HIV, we will come in and take care of that person. And then dementia. So dementia is something that occurs because you've got an Alzheimer or a Parkinson's, or frontal lobe type of dementia. That's how you get dementia. A lot of people say, my mom has dementia, can you come in and take care of her? We need to know what type of dementia we're dealing with. We need to know if we're dealing with Alzheimer's, Parkinson's, or, some type of frontal lobe dementia. And I think that's it. Does anybody have any questions for me?
So we had at least one in the chat, and I think there might be one in the Q&A. The first question says, do you stop medications specific to dementia when they are admitted to hospice services since the patient is in the end stage disease process?
Yeah, we take a look at the medications, and when some of these folks are on like Alzheimer's, on this dementia medication, we have to continue with it some of it because one of behaviors. I mean, you've got to look at some of the behaviors that are occurring and what's going on, in the home or the facility. So we have to look at some of that stuff, and we have to look at like what their status quo is. We don't want to take away a medication like for that type of a scenario. And, all of a sudden the patient's going to be falling out of bed all the time, or the patient's going to be, getting up, walking, falling. Like we have to have a conversation with the caregiver, the care team, the primary care person, and we have to sit down and we have to talk about what's reasonable, what is currently happening with their diagnoses, what is pertinent to their diagnoses, and what are the medications that we could possibly take away. Because sometimes, we go in with some of these folks and they're on 20 different medications. Well, that's not necessarily, it's not necessary, but some of the dementia meds for sure we have to take a look at and monitor very, very carefully because we don't want to create a problem. We want to help the patient, we want to help the family and the caregivers, and we want to keep everybody as comfortable as possible.
All right, thank you for your question. We have another one in the chat. It says, how do you feel about bowel protocols with the end of life?
Which protocols?
Bowel.
Bowel. Oh, bowel protocols. Bowel protocols, a lot of protocols that we have in place. When we get a hospice patient, when we get somebody that, we get the referral and we get a hospice patient, it's all depends, on that meeting, that initial meeting you have, and who's taking care of the patient and how often. Of course, you're not going to want somebody to hang out there and sit all day. And they're going to need to be moved and they're going to need to be turned. And we do put bowel protocols in place if it's somebody who's definitely somebody who's experiencing loose stools, or the flip side of that, with the enemas and stuff, for somebody who is maybe contracted and laying in their bed and has some issues with constipation. So those protocols we definitely put in place. I just took care of a woman this past Sunday. She needed a suppository. We had the enema ready to go, because a lot of times she eats and eats and eats and eats because of the state that she's in, though. She can't move around a lot. She can't move from side to side. She can't get out of bed. A lot of times we have to get this protocol moving, because she's not going, and you could definitely tell.
All right, thank you for your question. And that's all that we have so far, but if anybody else has a question, please submit it using either the chat or the Q&A. And
Mhm.
you can also raise your hand if you would like to request to be unmuted to ask your question out loud. And while we are waiting, I'd again like to invite everybody to next week's webinar, which is about education for nursing homes on sepsis prevention and enhanced barrier precautions. That will be the same time and place next Wednesday at 2 p.m. We also invite everyone to bring their questions to our live chats every Tuesday and Thursday at noon. One of our quality improvement specialists will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. You can find the links to our live chats and webinars in the newsletter we send out every Friday called the Last Minute Lowdown. And if you would like to be on that mailing list but don't think you're on our list yet, let me know. My email is ccaudell@qualityinsights.org, and we'll get you on that list. And I will drop my email in the chat right now.
I was I was going to put mine in there too, Kathy.
Yes, please do. I
Um,
don't even have yours
yeah,
pulled up here.
yeah. If anybody needs me or has a question, or if I can help with anything at all, I would be more than happy to.
Are you putting yours in, or if you want, I can drop it in? Is
Oh,
that,
okay. Go ahead. Yep, go ahead.
can you tell me what it is and I'll type it in?
Oh,
Sorry.
my yeah, my email is S as in Sam, Zito, Zito, at Connections Life Care Hospice.
Is that .org?
Yep, .com.
.com.
Yep.
Okay. Just put that in the chat. Sorry, I didn't have that handy. Okay. All right. So I believe that's it for the questions. I don't see any more in the Q&A or the chat. Shelly, before we wrap up, is there anything you'd like to add?
No, I just would, like to add that I always like to tell everybody that hospice is a benefit, and people shouldn't be afraid to use hospice. And the majority of people that get on hospice and their families are involved and their caregivers and stuff, it's like, wow, we this is not what we thought. This is not, we just thought it was doom and gloom, and that because hospice was coming, they feel like the Grim Reaper's not far behind. And when they get on and they see our services and see some of the stuff we can do and how much of the burden we can actually take off the caregiver's shoulders to get some of this stuff done, answer questions, make phone calls, get in touch with providers, DME, all that type of stuff. When they figure out that, wow, this is really something that I wish we called you sooner. So that's always a big soapbox of mine, that one, I'm really not the Grim Reaper. And two, we're trying to provide a comfortable environment for the patient and for the caregivers. And, we're just trying to do what we could to help everybody out. So, I hope that helps. If anybody needs hospice, don't be afraid to use it.
Thank you, Shelley. And we
Hmm.
didn't get any further questions, so I will go ahead and wrap us up. Before
Okay.
we sign off, we'd like to ask everyone here to please answer a short evaluation of today's webinar. It is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Shelley, I would like to thank you for this great presentation and for joining us today. And I'd like to thank everybody here for coming today. And we hope to see you again soon.
Yeah, thanks for having me, everybody. I appreciate it.